يا صلاح ده يطلع ضوضاء مثل الروبوت، نفس المشكلة.
اي دكتور، هو الافضل انه خلاص تصير لان المشكله من عند المايك تبع صلاح.
لا لا، ما أتصور المايك، لأنه نفس البارحة نفس السبب. المشكلة أتصور من زوم يا دكتورة، أتصور من
امم
زوم، لأنه أنا هاي ملاقيتني هاي المشاكل سابقا، يعني صار عندي هيك حالات.
امم
إحنا ما غيرنا شيء، نفس السيت اب، نفس الوضعية، ما غيرنا شيء. وده يطلع مثل صوت شو اسمه، يعني مثل الروبوت يطلع فروزن يعني. ايش الحل، نستمر ولا شنو دكتورة، تسمعيني؟
ايوه، يعني هو الان صلاح ما حيقدر يحرك سلايد صحيح ولا ايش المشكله؟
صلاح
يعني
تحرك سلايد ولا لا؟ الس-
تمام
تمام.
كذا حلو، والدكتور يصير الصوت من عندك.
تمام، واضح صوتي
نعم
الآن.
نعم، جدا واضح.
تمام صلاح ها.
خلاص دكتورة، البث المباشر جاهز، بسم الله نبدأ.
تمام، الله يحفظكم، شكرا لكم.
تمام. السلايد التالي تمام، السلايد اللي وراه صلاح، السلايد التالي صلاح. تمام. المشكلة صراحة اني ما راح نقدر نتناقش بهالحالة، لاني ما دا اعرف منو دا يرفع ايده اصلا يعني. أم... تمام، خلينا نشوف، نحاول ونشوف، تبا المستحيل. So we have this case, 4-year-old boy with a history of abdominal pain, pallor, jaundice. So you have a 4-year-old that having abdominal pain, pallor, and jaundice. And you're asked to look at the CBC and try to analyze it and come up with the diagnosis and workup. What do you guys think? دكتورة عبير، ما المشكلة، ما أعتقد راح تشتغل هالوضعية، لأنه صلاح مو يمي، وأنا أريد interactive session يعني. تلاحظين شلون المشكلة؟ يعني أنا أريد سيشن يكون وكيف أعرف يرفع إيده؟ ما يطلع عندي. دكتورة عبير.
دكتور، لما تفتح البارتيسيبنت اللي هو عددهم 26، حصل اللي رافع يده، او يطلع لك اللي رافعين يدهم، او
أنا ما
انه
يطلع،
ممكن على الشات.
المشكلة أنا ما يطلع يمي على التليفون مالتي، لأنه صلاح مو يمي، ما قاعد يمي.
مم. ممكن صلاح يفتح للجميع المايك.
صلاح ممكن تسمعنا؟ صلاح افتح المايك للجميع. سمعتنا صلاح؟ أنا برأيي ولو يعني I really hate to say this because tomorrow I have full day clinic as well, so I'll be very exhausted. So I think يعني أقترح إنه نسوي إعادة جدولة، رغم إنه هذا المقترح يعني شخصيا يأذيني، لأنه بكرة عندي عيادة كاملة الصباح.
طيب دكتور، ممكن نجرب مع اول سلايد ونشوف، لانه فتح لهم المايك، فنصير نشوف موضوع الانتراكشن. نجرب مع اول سلايد ونشوف الموضوع يمشي او لا.
تمام.
أنا موجودة دكتور.
يلا تفضلي دكتورة.
Okay, so we have 4 years old history with abdominal pain, pallor, jaundice, and lethargy. He's been traveling with his parents over the last 2 months in South America. The first felt unwell 2 days ago. And in the labs, he has low hemoglobin, WBC acceptable, and platelet acceptable, MCV acceptable, and CRB acceptable. He has high ALP, and the albumin also
So ALP is actually normal. ALT is normal. So the liver enzymes I don't want you to worry about.
Okay.
I want you to focus on this. So this is a station to test your knowledge on interpreting the CBC in this context.
Okay. Regarding the blood film, he has Howell-Jolly bodies, abnormality and shaped red blood cells,
Right.
anisocytosis with normochromic normocytic anemia.
Excellent. Yeah.
What is your diagnosis? I'll go with malaria.
Okay. So the malaria. Okay. Why would you go with the malaria? Wouldn't you see more high white blood cell and high CRP?
Yeah.
And there is no evidence on malaria film, so you cannot assume. And they're giving you something, holy jolly body, right? So Asrar, can you speak up, Asrar? You said something hemolytic anemia.
Yes, doctor. Hello. I think could be spherocytosis as the MCHC is high, or could be thalassemia as he is having target cell or holy jolly bodies.
Right. So I think this is hemolytic anemia, whether it's extravascular or intravascular hemolytic anemia, that's something to be decided later. So I would say the diagnosis is hemolytic anemia. I'll leave it at that. If you get probed and ask what could be, you can say that could be extravascular hemolytic anemia, like a spherocytosis or a G6PD or sickle cell anemia, or that could be just some sort of acquired autoimmune hemolytic anemia, or MAHA, which is a microangiopathic hemolytic anemia. Now, the next question, what would you do as a workup? I would do a complete blood film and probably send a 4-panel for G6PD and osmotic fragility tests along with the other workup for intravascular hemolysis workup. Okay, السلايد التالي صلاح. تمام. So الآن عندنا we have 14-year-old boy present with a chest infection and erythematous rash on his right ankle and wrist and neck. So you have child with the chest infection and a rash. Otherwise, he looks healthy, young boy. You look at his CBC, seems to be okay, except the platelets are 50, and the PTT slightly prolonged, and otherwise his liver enzymes seems to be okay. INR slightly increased, or increased actually, not slightly. So any taker for this question? Anyone? The mic are open. Go ahead and feel free to jump in. Otherwise, we'll be staying probably praying Fajr here. Chop chop.
Yes, doctor.
Yeah.
Yeah, yes, I think this patient, as he is having a platelets low with prolonged BTT, I was thinking about Von Brandt type 2B.
Right. Okay. So Von Willebrand, that's a good thought actually. Now, what if I want to make it more clear that he had repeated chest infection?
Wiskott-Aldrich syndrome.
Excellent. So Wiskott-Aldrich syndrome. So this scenario is poorly written. It's taken from a book. So I think they should make it clear. And I agree with you. That could be Von Willebrand, right? So now they should make it clear this is a Well, all fairness, I go back to the question. Erythematous rash, it's not a bruises, right? So it's giving you a hint. This is eczema, right? So I think with a chest infection, eczema-like rash, and a platelets of 50, that's Wiskott-Aldrich. Now, what is the next step in workup? Then you say, I would do a clotting factors, probably consider thymic scan. What is the mode of inheritance? You will say this is X-linked. What is name of the 3 affected system? You say the skin, eczema, immune deficiency, and the platelets. Risk for what? What is the risk for? They are at risk of leukemia, lymphoma, and risk of recurrent deep-seated infections because of their immune deficiency, right? And they are risk of recurrent bacterial and viral fungal infection because, as you know, Wiskott-Aldrich is both a humoral and cellular immunity has been affected, right? Okay, slide التالي صلاح, next slide. Okay, so we have a 6-month-old present to the pediatric emergency. You look at his face, there's extensive vesicular ulcerative lesions on the face and the upper body. You take further history, he's failing to thrive, he has recurrent infection, he has been hospitalized in the past with the severe respiratory infection. The child looks sick, he's irritable and has a high-grade fever. What's any taker for this case? What do you think is the diagnosis and giving this case, and what is the underlying pathophysiology?
I think this is immune deficiency.
Right. So what is the diagnosis in this case? It's not. I'm not asking you the underlying pathology. I agree with you. Underlying pathology is a SCID. But what is here? So you would say this is herpes, invasive cutaneous herpes. The underlying pathology, you say, is SCID. I agree with you. The immediate long-term management, you need to cover appropriate with the broad spectrum antibiotic and including a cyclovir. And you would do immediate immunology consultation. Those the old days we call them the bubble babies. You have to protect them. And the long-term management, of course, somebody said BMT, bone marrow transplant. I agree with that. And what additional test needs to be performed? You need to do a full, complete blood count. You need to do a lymphocyte subset. You would see low CD3, CD4, CD8, and you also very low B cell subset and very low NK cells. And you can see a low IgG, IgM, and you will do in this case particularly not related to SCID, but this case is you need to do viral PCR for herpes, right? And what additional tests we talked about? What are the key consideration? Family education. You need to counsel them. This is a SCID. This is a life-threatening immune deficiency. We need to be careful about risk of infection and
Doctor, acquired immune deficiency like HIV.
What's that?
Maybe acquired immune deficiency.
It could be. Now, I haven't told you. Right. I mean, that's right. It could be HIV, but I haven't told you any HIV risk. Right. So, if you would say, I think to be safe, you would say, I think this is a immune deficiency. I have not given any risk factors for a secondary immune deficiency. I would assume this is a primary immune deficiency, given the child been admitted in the past and this young age. If they're giving me history, the mom has been promiscuous and sleeping with God knows with the whole city, and she has a recurrent what is it called, sexually transmitted disease, or maybe it's been incarcerated and it came out of a prison, or maybe came from East Europe where HIV is more prevalent, then I would say yes, that could be. But I agree with this is that's a good thought though. Slide التالي صلاح. Good. So another infant presenting with extensive crusted inflamed lesion on the cheek, shown in the image, has recurrent infection and history of PTKI and easy to bruise. What is the diagnosis? I think this is kind of repeated, but I just want to drive the home for immune deficiency. So somebody, this is Job syndrome. And what is Job syndrome? I think you want to say this is hyper IgE syndrome. No, this is not hyper IgE syndrome. Hyper IgE syndrome comes with the deep-seated infections, deep-seated abscesses, and we call them, right. Yeah, so this is somebody, this is said which is Wiskott-Aldrich syndrome. I agree with you. This is Wiskott-Aldrich syndrome. And again, the triad is a eczema, thrombocytopenia, and immune deficiency, which is the mixed immune deficiency, which and the thrombocytopenia is actually, they have micro platelets, smaller platelets that cannot form normal clot and lead to excessive bleeding. Also, they have recurrent pyogenic infection in the infancy. And they kind of present with the water, bloody diarrhea and PTKI in the first month of life. And there are risk of infection, mainly encapsulated organisms like H. influenzae and the others, right? And now they can have, if they ask you what other associated manifestation they might have, they have autoimmunity, they have hemolytic anemia, vasculitis, inflammatory bowel disease, and there are increased risk of malignancy, especially B-cell lymphoma and leukemia, right? So and they usually have high IgE and have high IgA, opposite to the other Ataxia-telangiectasia, when ataxia have low IgA and high IgM, okay? And they have a profound eosinophilia on the CBC. And when you do vaccine, they have poor response, but they have okay response to the protein vaccine, right? We can go on and on and on. And splenectomy may help to maintain platelets. Eventually, the bone marrow transplant is the cure. Okay, you need to support them until then by giving antibiotic and screening for the autoimmune condition. Slide التالي صلاح. Excellent. Any taker? I had a long day and it's been rusty voice. Any taker?
Ataxia-telangiectasia.
Yeah, tell us about, tell your colleague as if you're the speaker. Explain to them what's going on.
This patient, I can read, a 5-year-old child present with progressive difficulty walking, clematis, and frequent falls. So
excellent.
The child has the history of recurrent pulmonary infections. Regarding the picture, there is in his eyes and ears, this seems to be a Ataxia-telangiectasia because there is hypervascularization.
Right, so this is telangiectasia.
Yeah.
What's your name, Doctora?
Manal.
Manal. Allah يرضى عليك. ما شاء الله عليك. Allah يوفقك إن شاء الله. I hope you're going to be a really excellent pediatrician. Thanks for the spirit of participation. Okay, excellent. So this is Ataxia-telangiectasia. Now the workup, where is the problem? The problem in the ataxia, it's a mutation in the ATM gene, and you can confirm that by gene sequences. The function of the ATM gene is really unclear, but what it seems to be, they think it's detect the DNA damage. When it detects the DNA damage, it blocks the cell growth from division until the damage is repaired. And the biggest problem with the abnormal DNA repair, they can have increased sensitivity to radiation. So we say part of the counseling piece is if you ask about counseling, you say avoid ionizing radiations. What are the other physical features in ataxia? You can have ataxia, which is cerebellar. Usually early in toddler, they become clumsy, wobbly, and may be mistaken for ataxia cerebral palsy, ataxic cerebral palsy. And you can put ataxic cerebral palsy as one of the differential diagnoses. Usually by 10 to 12 years of age, they are wheelchair bound by teenage year. The other manifestation, physical finding, is telangiectasia, usually prominent on the face and the conjunctiva and the earlobes, and usually appear not early, appears about by 4 to 5 years of age. Other features, they have a progressive neurodegeneration. They will have dysarthria, very unclear speech articulation. They will have nystagmus. They will have oculomotor apraxia, which means they are inability to follow object and will move their head to compensate while looking for an object. If you point to something, say, look at it, they cannot move their eyes. They move the entire head toward it, right? And the other feature is the immune deficiency. And as we said, this is the opposite to Wiskott-Aldrich. They will have low IgA, where Wiskott-Aldrich will have high IgA. Okay, and they have a lot of sinopulmonary infections, and eventually they will have a bronchiectasis for repeated chest infection. The other trivia in the exam, you need to screen them for a alpha-fetoprotein because they are at risk of hepatoblastoma, right?
Genetic.
And go ahead.
Even genetic tests?
Yes, genetic tests. You need to do genetic tests to confirm for the ATM, not ATM machine though, ATM gene mutation. Okay.
Yeah.
So slide التالي صلاح. So just I'm going to run it through this. So this is, we're still in the immune deficiency though. So because I want to drive home immune deficiency message. This is a 5-year-old, this is not immune deficiency though. This is 5-year-old boy present with the recurrent skin infection. He has required drainage of abscess on 2 occasions. There are no other concerns about him. You look at the CBC. What do you think about the CBC here? So he has neutrophilia. He has a, okay, so Dr. Asala, talk to me.
Okay, doctor. On the CBC, he's having neutrophilia, as well as the other lab, the immunoglobulin in the normal range. That's why not B cell defect.
Excellent.
And
so what's going on? Just go for the chase. Go for the meat. What is it?
It's going with CDD as the patient have recurrent infection and recurrent abscess with the neutrophilia, mainly phagocytic defect.
Excellent. So this is CGD. What is CGD? Chronic granulomatous disease, right? So what is it?
It's a problem in the phagocyte. It's phagocytic defect.
Right.
Killing defect.
They phagocyte the organism, the bacteria, like Haemophilus influenzae and the pneumococcus and whatnot, and the strep pneumonia, whatever, but they cannot generate the oxidative burst to kill it. So they keep engulfing and engulfing and engulfing, and you end up with a lot big abscesses. We call them the cold abscesses, right? And they get decolonized, especially with the Staph aureus in this case. So the diagnosis would be, you would say the child is colonized with the skin infection with the Staph aureus. The underlying issue is CGD. How do you diagnose? You do skin and nasal swab, and you do, for this case, swab for the staph. for MRSA, but the definitive diagnosis is you do MBT, which is nitro blue tetrazolium test, to test for oxidative burst of the neutrophil. And hence the neutrophilia, because they cannot kill and generate the burst, they try to compensate, they mobilize a lot of neutrophil. Next. صلاح السلايد التالي. And that's the cold abscess. You can, this child having this big abscess in the axillary, and you get all this big lymph nodes filled with the abscesses. No, so the message I want to drive home is, if you are faced with the scenario of a child having recurrent infection, you suspect inborn error of immunity. Believe it or not, there is something called inborn error of immunity. It's not inborn error of metabolism. The new nomenclature is called inborn error of immunity, IEI. So if you have suspicion of recurrent infection, you say, well, is it T cell? And if it's B cell and phagocytic or complement, if it's bacterial infections or mycobacterial viruses like CMV, EBV, parainfluenza, or fungus, you think about this is likely T cell. If you get mostly bacterial, especially the encapsulated one, then you think that could be the B cell, especially if you have parasitic infection with it, Giardia lamblia or enteroviruses. The scenario presented with the CGD, when you have big abscesses and cold abscesses, and you get the child colonized with the Serratia marcescens or Burkholderia, similar to kind of picture of CF, you think of this as a phagocytic issues. And if you have something to do with the Neisseria meningitis, especially the complement, or with the autoimmunity, you think about the complement issues, right? السلايد التالي. But if you say صلاح، هو هذا السلايد اللي تكلمنا عليه، انت ما حركت لعد؟ تمام، هو هذا اللي تكلمنا عليه. ما اعرف شفتوا السلايد الاول ولا لا؟ شو تتكلم عليه؟ تمام، هذا السلايد هذا تكلمنا عليه، هذا اللي تتكلم عليه الان، ما اعرف شفتوه ولا لا. تمام، لانه انا دا اباوع على الكمبيوتر وهو دا يحرك على التليفون، فاني عيني على الكمبيوتر يعني، فدا يصير لاج يعني. ممتاز، شفتوه، شكرا اصاله. السلايد التالي صلاح، عفوا، اي هو هذا السلايد، خليك خليك على هذا السلايد، ارجع لذاك السلايد السابق. السلايد السابق، هذا السلايد السابق صلاح. تمام. But if you don't have a case of recurrent infection, but you have predominantly autoimmunity, inflammatory bowel disease, and you have autoimmune vasculitis, autoimmune hemolytic anemia, whatever, you think about different pathway of the immune deficiency. You think about the autoimmune cytopenias, lymphoproliferative. You think about the immune dysregulations and the lymphoproliferative syndromes. You think about the immune dysregulation like Apex, IL-10 deficiency, or the others. So I'll leave that, especially when you have a recurrent fever, arthritis, and SLE-like picture. So you think of those. السلايد التالي صلاح. So now the slide التالي, so you need to think about the primary immune deficiency when you're faced with one or more of the following signs. If you have 4 or more ear infection within a year, 2 or more sinus infection, 2 months or more being an antibiotic with little effect. If you have 2 or more pneumonias, so 2 or more sinus, 2 or more pneumonia, 4 or more ear infections, 2 or more deep-seated infections, and including septicemia. And if the child is failing to thrive, if you have recurrent skin or organ abscesses, if you have recurrent thrush in the mouth or fungal infection, if you have needing IV antibiotic to clear any infection, you need to think of the primary immune deficiency. Also, if there's a history of primary immune deficiency and a setting of consanguinity, infantile death, and affected maternal uncles. You think about the slide التالي. And also you think السلايد التالي صلاح. You also think about the pure primary immune deficiency. You have recurrent biogenic infections. You have illness. If you give vaccine like MMR, varicella, and the child get really sick, you say, "Oh, that could be immune deficiency." If you give a blood transfusion, anytime you get a blood transfusion and you have adverse reaction, you may think of the primary immune deficiency. If you get delayed wound healing, especially if with lads, leukocyte adhesion defects, they have poor wound healing. And if you have the question they love in the exam is delayed separation of the umbilical cord, which is especially more than 3 weeks, that's likely in the lad adhesions defect, right? And also if your kids has some sort of skeletal dysplasia, congenital heart anomalies, and dwarfism, albinism, thrombocytopenia, or being dysmorphic. السلايد التالي صلاح. And that summarize the immune deficiency. If your child is having pneumonia, otitis media, and osteomyelitis and meningitis, think about the humoral pathway, like immunoglobulins. If you have a cutaneous candidiasis, you have more opportunistic infection. You think about the T cell and so on. You can read that. I think we already covered it. السلايد التالي صلاح. Now, more questions. So we have 7 days. I have the urge to skip these questions because I have more important slides. So let's power through them. 7-month-old present with jaundice. He is pale. He's lethargic. Over the previous months, he has been started on solid food, and last week has started on malaria prophylaxis because he was traveling with his parents to Kenya this week. Now you check his hemoglobin is low. Right. So talk to me, Al-Anud. You said G6PD. Talk to me.
Yes. No.
Yes.
There is anemia with normocytic and total bilirubin high.
Right.
With history of medication and peripheral blood film with hemolysis.
Right. And malaria prophylaxis, which are known to have a hemolysis with the G6PD, right?
Yeah.
So this slide it tells you again you need to be you need to know your CBC. You need to know how to read your CBC and get a lot of information. You need to know your hemolysis. You need to know the medication for G6PD. So the diagnosis would be G6PD would be the next setup in the step in the workup. You need to do the G6PD assay, and the inheritance is what, Al-Anud?
It's an X-linked recessive.
Excellent. Good for you. Proud of you. Good. السلايد التالي. Okay. Al-Anud, I'll push you further. Take this question, please.
A 10-year-old presented with the generalized edema, clubbing, and tiredness. This has been going on for the last 2 months, and he gets tired easily. His parents are from
Slovakia. He's Slovak.
And
he recently moved to this country, to Saudi Arabia, right?
So
you look at his hemoglobin is low, his ESR is high, and his CRP is okay. Platelets are okay. Sodium is slightly low. Bilirubin is okay. Albumin is at 12. Okay, so he has high ESR, high albumin. He has edema. He has clubbing, and he gets easily tired. So you do sweat test is okay. You do MRI of the abdomen. There is a wall thickening of the small bowel. What would you most likely diagnosis? One diagnosis.
I don't know. Maybe neuroblastoma. Not sure.
Oh my goodness. Okay. I have edema, I have clubbing, I have tiredness. But good to try though. Okay. Okay. Did I get disconnected? Hello? Can you hear me?
Yes.
Okay. So Abdullah, talk to me. You said a protein loss. Protein losing enteropathy. Right. That's a protein losing enteropathy. If you want to pick one pathology that could lead to that, what would it be? With the small bowel wall thickening. It's a screaming in the face. Yes, Crohn's, Asrar. This is a Crohn's. I agree with you. Differential diagnosis would be any other differential diagnosis of protein losing enteropathy, celiac, small bowel TB, blah, 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 blah. And what do you need to do next? You need to consult your GI. They probably do a celiac serology. They probably do a chest X-ray and maybe TB skin test. And finally, they need to do a GI, like endoscopy, upper or lower endoscopy, right? So hypoalbuminemia, you need to be aware of it. You need to know how to fecal calprotectin. I agree with you. You need to know about the hypoalbuminemia, whether it's a nutritional, whether it's dumping in the kidney, like nephrotic, whether it's a liver in the cirrhosis, whether it's a heart, whether heart failure, whether it's a GIT, like inflammatory bowel disease, whether it's a lymphangiectasia, especially primary lymphangiectasia, whether it's a sarcoma or TB bowel, especially TB ileitis or amyloidosis, all these things. Slide tally. Right. So, Asrar, you want to take that?
Sure, doctor. This is a 5-year-old baby girl present with lethargy, possible seizure, and not feeding very well. The head ultrasound showed intracerebral bleeding. The CT scan showed no subdural bleeding, but confirmed the intracerebral bleeding. MRI showed no blood vessels abnormality.
So what do you think? What's going on? Your CBC seems to be okay-ish, except the PTT is very prolonged. Right.
I know.
And the rest of the liver enzymes, INR is prolonged as well. The PTT prolonged, the INR prolonged. So what is that?
So it could be factor deficiency, to be.
Right, that's a factor deficiency. What factor deficiency? Dependent on what? He's 5 days old.
Yeah, vitamin K.
Right, and I told you this is a breastfed baby, right?
Yep.
Right, so the mom refused the vitamin K injection. She's breastfeeding. This is hemorrhagic disease of the newborn. Diagnosis, treatment, you need to give IM vitamin K. Can you give oral? Oral is not as effective as the IM. The IV is not as effective as the IM. IM is the best. So that's the drive home message. The slide tally. And you need to appreciate 1972, which is factor 10. 972 is the factor vitamin K dependent. Anyone taking this question quickly, please?
I'll take it.
Okay. Your name, Doctora?
Asmar.
الله يرضى عليك. تفضلي دكتورة.
A 13-year-old girl presented with pulmonary crashes, multiple bruises on her legs and forearm. She is well, with no organomegaly or large lymph nodes. Her hemoglobin is 12.7, WBC is 11, and platelets is 240, and BT is 10. Bleeding time is 10 minutes, and ABTT is 90, and INR is normal, I think. Blood film shows lymphoblast and anisocytosis.
So what is that?
With this pulmonary crashes and multiple bruises, but she has normal platelet. I would think of it's not ITB for sure. For it could be von Willebrand disease.
I agree with you. I think it's mostly fitting with the von Willebrand, right? Your treatment would be supportive with factors. I think there is something wrong with this equation. I am not entirely sure what is it, but I think there is something wrong with this equation. If you give me 1 second, I will figure it out. I think there is something wrong with this equation. Okay. Right. So that's so 13 purpura crash, bruises. She's well, no organomegaly or lympho. Okay. Okay. So the textbook question answer says this is henoxulum purpura. I kind of disagree. With this PTT is high, and yeah, okay. Well, the blood film is showing no blast and isocytoses. Now, they could have a prolonged PTT, and PT, yes, the bleeding time is slightly elevated as well. Now, the question is, could that be, agree with them, and it's henoxulum purpura? I have a trouble accepting this kind of answer. But I think your homework to say, could henoxulum purpura have some sort of a bleeding tendency, especially if they have some sort of vasculitis and trapping, like consumptive thrombocytopenia and factor usage. I'm having trouble accepting this kind of answer. Okay, I'm not sure if one of the colleague hematology is with us, can support us with this question, but I really doubt it. So just throw this question to the garbage. السؤال التالي. "13-year-old with the abdominal pain, high temperature, and abdominal pain, high temperature, and she is vomiting. And you've done urine microscopy. You have white blood cell, no nitrate, red nitrate, but a lot of red blood cell, a lot of protein. Renal ultrasound shows multicystic kidneys. And so whether it's this diagnosis, this is a scenario trying to test you on reflux nephropathy investigation. You do indirect MAGA3, and you do, so this is a reflux nephropathy, like VUR, okay? So you need to know that. I'm not excited about this question anyway. السؤال التالي صلاح. So this is a 10-year-old. She has diarrhea and then blood in the stool, and you look at the urea is quite high, and she has anemia, and she has a so this is a scenario of hemolytic uremic syndrome. Okay. What to monitor for urinary output. The treatment is restrictive fluid. Okay. I need to be aware of the CBC finding and the lab testing of hemolytic uremic syndrome. Okay. And they have the microangiopathic hemolytic anemia, which is called MAHA. Okay. السلايد التالي صلاح. This is another nephrology. 6-year-old present with a swelling of the face scrotum. You look at his albumin is quite low. He is swollen. Urine output is high, and this is a nephrotic syndrome. Diagnosis: 24-hour urine collection for a protein, and the treatment is steroid. السؤال التالي صلاح. Okay, and you take care for this one. This one I think is interesting. Any taker?
Yes.
Yeah, go ahead, Victoria.
A boy was born at 32 weeks gestation to a mother with type 1 diabetes. He was ventilated from day 1 to day 7 and was then on NCPAP of 7 cm water pressure in 40 to 55% O2 until day of 27. He was transferred to tertiary pediatric hospital for further testing. He was edematous for the first 7 days, had wide spaced nipple, low 6 years, short neck, dilated cardiomyopathy, and stridor. A positive genetic testing showed the presence of the PTPN11 gene. Latest results are as following. Capillary blood gas, BO2 5, CO2 8.12, pH 7.30, bicarb 23 طيب
So
albumin
basically seems to be okay, right? Ventilation,
I
right?
think it's Turner syndrome. Huh?
So he has albumin. Albumin is 27, and his sodium and other salt is okay.
Yeah.
Bilirubin. Who said Noonan? You want to speak up? Whoever, I did not catch the name.
Maybe, yeah, no, maybe I think because he's boy.
Right. Yes, Noonan. You said Turner, so you were thinking about girl.
Yeah, boy.
Right. Yes. So this is Noonan. Would be what other two investigation you need to know to do is you need to do a chest X-ray and you need to do echo. And so you need to think about the Noonan, and especially when there is a IR white set and especially diamond kind of shaped looking eyebrows and small upturned nose, and most cases with the low set, the ear are low set, and over 90% of the cases have like the ears a little bit backward and rotated with a thick helix. I'm not sure if you know what I mean. And the groove, the philtrum, is deeply grooved and can be seen almost in every cases. And they would have poor tongue control, and they have okay, and a lot of developmental issues and pulmonary valvular stenosis. That's the common in half of the patient. So pulmonary valvular stenosis, that's and they will have webbed neck, lack of sexual development. They have undescended testes. They have motor delay. They have poor coordination, and they have right.
Yes.
What else? And they will have a clotting factor, especially with combined coagulation deficiency, right? Good. So slide التالي صلاح. Yeah, I think I got the feedback. You guys don't get a lot of cardiac catheterization question. Do I skip that, or you want me to discuss that? Quick feedback. Skip. Skip. Okay, next. السؤال التالي صلاح. تمام. So you have 11 years old from Pakistan referred to you with jaundice and pallor. So I want you to focus on this question. He's Pakistan, jaundice and pallor. And Dr. Muhammad Al-Amir, you want to take that?
I already talked.
Okay, go for it, buddy.
So this is 11-month-old Pakistani boy, referred with jaundice and pallor.
We cannot hear you, Dr. Muhammad. We cannot hear you. You're very far.
This is 11-month-old Pakistani boy. Can you hear me, Doctor?
Keep going.
11-month-old Pakistani boy referred with jaundice and pallor, his hematological investigation revealed we have low hemoglobin, 4.3 grams, platelet lower side normal.
So platelets okay, white blood blood's okay, Retic is 9, MCV 77 low, the rest is okay, no basophilic sibling. I heard in the I heard AHA, which is I think autoimmune hemolytic anemia. No. So the and I heard a malaria. Possible. Again, there is no history of except the visit to Pakistan. But again, I cannot assume this Salmonella typhi possible. But what if I told you I've done a blood test and this is his next slide, صلاح السلايد التالي. and هذا شو اسمه electrophoresis. What do you guys think? دكتور محمد.
So hemoglobin A is 2.6.
Yeah.
And hemoglobin A2 is 2.7. Could be crystal disease.
Okay. So Dr. Asrar, talk to me. You got it right.
Yes, doctor. I think this one, it is one of kind of beta thalassemia, minor or intermediate. It's not
Right
major,
as well.
sorry.
Okay, so I agree with Nada and Asrar. This is beta thal major, beta thalassemia, because go ahead. Go ahead.
Yes, doctor. I was just asking, is it major? Because there is A. I was thinking if it is minor or intermediate.
I mean, the A is it's how much is the A? It's nothing, right?
Yeah.
Right. It's so this is a beta thalassemia, right? And so I think there would be beta thalassemia, and now I think the slide التالي صلاح, and I think they might test you on. Was that? So I think you need to probably. I'm not sure what's. You guys correct me if I'm wrong. I haven't done the Saudi board. Does somebody want to say something? I hear like a bit of noise. No? So I think you need to be familiar with the hemoglobin electrophoresis. Hemoglobin itself, like when you do the electrophoresis, the different hemoglobin have look different during the electrophoresis. Usually the electrophoresis separate hemoglobin protein based on their charge. The hemoglobin A seems to migrate closest to the positive pole, the anode, due to the normal charge. And the opposite to that is hemoglobin A2 and the C. And the S and F kind of balance in the middle, right? So when you have a sickle cell, when you have a predominant, when you get a slide التالي صلاح, when you get a predominant S, you think about cell. So if you guys look at this one, which one do you think it's sickle cell? Which number? Because you see predominant 4. Yes, I agree with you, Asala. That's kind of sickle cell. What about a beta thalassemia? Which one? Is it 2? 2, you need a predominant F. I think 3 probably. You need a lot of F in the thalassemia, right? And when you have 8, you have A and S. 8, number 8, you have A and S, that could be trait. And the 7 is mainly S and C, so that's sickle cell, like S and C disease, whatever it's called. Anyway, so that you need to be familiarizing yourself. So the slide التالي صلاح. You need to be you need to know what's the normal electrophoresis looks like. The normal, you're going to see a bit of hemoglobin, a tiny bit of hemoglobin AT, a lot of hemoglobin A, and tiny bit of F. The beta thalassemia is the opposite. You're going to see the trait soul. You're going to see a bit of more of A2, less of the A, and a little bit of the F. The thalassemia major is the F is the majority. And the sickle cell anemia, you're gonna the C or the C depends on the type, whether S or C. You're gonna see either C or the S is the bigger one, and the trait kind of still in the middle. Slide التالي صلاح. Right. Any taker? What's the diagnosis here? So this is the one that we saw previously. That's called the I think it's called alkaline gel electrophoresis. This one is a different method of electrophoresis called HPL, which is kind of high performance liquid chromatography way of looking at the hemoglobin electrophoresis. Any taker for this one? What is that? Even if you don't know how to read HPL or read electrophoresis, Asala, what is that?
Maybe it's normal because the A is normal range and the A2 is normal range, but no F.
Excellent. So what is that?
Alpha thalassemia.
That's a normal hemoglobin electrophoresis, right?
Mm-hmm. Yes.
So when you have thalassemia major, minor, the sickle cell, you're going to see, as we said, hemoglobin S. The trait, you're going to, A and S, the thalassemia major is mostly 90% hemoglobin F, 10% of hemoglobin A2. And the minor is kind of, A2 is increased, and the F is about 20%. It's a bit more or less than the major. Slide التالي صلاح. What about this, Asala?
This having hemoglobin S and there is hemoglobin A. So
right.
This is going with sickle trait.
Okay.
And the A2 2.9. So can be beta thal sickle trait.
Right, I agree with you. Sickle cell thal, right?
Mm-hmm.
I agree with you. Okay. Slide Tali Salah. So shifting gear to a different beast. Asala, you want to take that?
Okay, doctor.
Give it a try. It's challenging, but give it a try.
Okay, sure. These are the result of ITT, TRH, LHRH in the short of 12 years old boy. And this is the result for glucose, cortisol, growth hormone, thyroid, TSH, FSH, and LH.
Right. So what would be what's going on? So let's go through before we answer the question. What is exactly that? So there is I'm just going to help you there. So there is, when you give the insulin, there's insulin tolerance test, and there's the TRH stimulation test and the LHRH stimulation test. This is in a setting of a growth hormone. Yes, a growth hormone stimulation test, Al-Anud said. So when you give the insulin tolerance test, shows when you given the insulin tolerance test, the ITT, what happened with the insulin? You can see a nice cortisol response, right? The 0, and you can see a nice response to the cortisol. That means indicate the adrenal axis is working properly. But when you give the growth hormone, response is quite optimal and delayed. That could be suggesting a growth hormone deficiency. When you look at the TSH response is exaggerated when from the 2 to 13, that could suggest hypothyroidism or maybe a delayed TSH feedback. When you look at the FSH and LH response to LHR stimulation is normal, that suggests the gonadotropin axis is functioning properly for age, right? So that is suggestive of partial growth hormone insufficiency. And the reason I say partial, because the normal response for growth hormone stimulation test should be more than 15 to 20, depending on the assay. So when you have the growth hormone, it's not reaching more than 15. So this is around kind of 8 around 20 minutes and 7 at 30 minutes, and it dropped way below later at 4 and 90 minutes. So when you have a partial response less than 7, this is a growth hormone deficiency, right? So the question, that's the diagnosis, growth hormone deficiency. What would be the next step? You want to make sure that the sella torsica is normal. You want to make sure that there is no craniopharyngioma or tumor, whatever. You want to do the MRI brain, right? And of the pituitary gland, right? And also suggest underlying causes. Again, as we said, that could be hypothalamic or pituitary dysfunction, whether it's a pituitary adenoma or a craniopharyngioma. Or it could be just constitutional growth delay. Although this is a common cause for short stature, it would need to be differentiated from the pathological causes by clinical context and a further evaluation. So the summary, the main concern in this scenario is trying to test you how to read the growth stimulation test and whether you can appreciate this is a growth hormone deficiency or not, and what would be the next step would be brain imaging to look at the sella torsica and pituitary gland, right? السؤال التالي صلاح. هسه عاد بدينا الشغلات الدسمة شوي. Any taker for this question? دكتور محمد. دكتور محمد تفضل. دكتور العنود. أسرار.
دكتور I can read it.
Manal, anyone?
I will check.
Yes.
Yeah, go for it.
Okay.
دكتورة
This is a
منال.
lung function.
أيوة.
تفضلي دكتورة.
These are the lung functions of a child having difficulty in breathing. So this is the function test, اللي هو spirometry result. It gives for me I think this is a restrictive lung disease because no change in measurement before predicted and measured. It's 2%. I think it should be more than 12.
Mm-hmm. So this is restrictive.
VC, if VC is less than 80, which is abnormal.
Okay.
EV1, if EV1 normal. If EV on ratio is 2, which is abnormal. Low, I mean. I think it's going with the restrictive lung disease.
Right, but if you look at the FEV1, FEVC ratio, is it normal or low?
Low, it's low.
It's actually normal. I agree with Asala. It's normal. It's 90% of the the measured, the predicted is 90, the measured is 92, right?
Yes.
Don't confuse with the percentile. So the measured is 92, right?
Yes.
Right. So this is normal. And the only time you get a normal FEV1, FEVC ratio when you have low FEV1 and low FEVC, so the ratio stays normal. And that's the only thing you get that when you have a restrictive lung disease. And I agree with you. And this restrictive lung disease could be inherent to the lung, like pulmonary fibrosis, or in the wall, like chest wall deformity or scoliosis, or maybe in the muscle, like a neuromuscular disorder. or maybe in the lung as pulmonary fibrosis or interstitial lung disease. Okay, so that's the likely cause, or maybe causes like CF. I agree with you, Dina. Oh, actually, no, I take it back, Dina. CF is mostly obstructive. Okay, so slide التالي صلاح. So the take-home message from this slide is you need to be familiar with your pulmonary function test. So you can see that FEVC, the vital capacity, FEV1, FEVC, and the FE, 25, 75%. By the way, the last one is measure of the small airway capacity and compliance. They are all of them low, except the ratio, because in the restrictive, both of them low. And that's why it becomes normal or slightly high. Or in the obstructive is the opposite. Usually the FEV1 is quite low, and the capacity is kind of stays normal and maybe slightly enlarged. That's why you have a low ratio, right? Next. And obstructive lung disease, you may think about bronchiolitis, asthma, bronchiectasis, and cystic fibrosis, and restrictive lung disease, as we said earlier. Slide التالي صلاح. So this is you need to be familiar with the, it's called the flow volume loop. This is a flow volume loop. You can see on the x-axis, which is the volume loop, represents the volume of the air exhaled or inhaled from the lung. The top one is exhaled, the bottom one is inhaled. That's the x-axis. The y-axis is mostly on the flow in the liter per second. So and you can see the peaked expiratory flow and the FEV1, the FEVC measurement there. So you need to be familiar yourself with the flow volume loop, right? Slide التالي صلاح. And again, so when you have you look at this one, for example, the first one is the top left of the slide. This is a normal spirometry graph, usually a nice rapid rise in the flow, peaking quickly before the gradual decline. And this is indicating of efficient lung function, where the air can be expected swiftly and fully. In contrast, the middle one, which is you have a bit of a plateau, and the plateauing it's just not reaching the in the flow curve. It's not reaching. I cannot point. It's very hard. So you can see the green line is not reaching the horizontal normal peak line quickly. It's taking a bit of a gradual slope to reach it. And that is reflective on the flow volume curve is as a concavity. It's called coving because there is a mildly decreased peak expiratory flow. It's not flowing as quick as possible. That's why leading the coving. So when you see that in the exam, you say this is obstructive pattern. But if you have everything identical to the normal, but everything is small, you think this is a restrictive pattern, right? So that's you might get tested on these, showed one of these images and say, what is that, right? And slide Tali Salah. And that's another one, same thing. I think the same idea. The top one is normal. The middle is kind of obstructive. I want you to pay attention to the right middle, the one that looks like مثل البيضة, egg. This is commonly tested kind of when you have a fixed airway obstructions. especially with the vocal cord dysfunction or vocal cord dysfunction. And then they give you a scenario of a teenage girls, especially girls, and she's athletes, and she start running and have exercise, and suddenly has a choking episodes, and she cannot breathe, and that's called focal cord paralysis or focal cord dysfunction. And you do the pulmonary function test. Of course, you mimic the exercise. Either you tell them to exercise, or they give them certain inhaled material. I forgot what it is, whether it's a 3% saline or salt, whatever. And they try to mimic the exercise, and they do the curve, and it becomes like this. And this is a diagnostic of the vocal cord paralysis, and the rest is for you. Next slide, Tali Salah. Oof, that was quite a marathon. Okay, next. Who's going to take that? Anyone? دكتورة العنود؟
Yes, doctor.
يلا تفضلي دكتورة.
A baby born 26 weeks of gestation was ventilated from the age of 2 minutes and course of given for HMD. On day 3, the ventilator setting were as follow: a rate 50 per minute, IT 0.45, ال BIB over B 18/4, وال FiO2 35%. Blood gas, pH 7.34, CO2 5.6, oxygen 6.2, the base deficit -3.4, MAP 32, without any tube support. 4 hours later, following the last gas, the oxygen requirement increased to 70%, and the baby became bradycardic, and arterial blood gas was taken at this time and showed the following: pH 7.21, CO2 8.8, oxygen 3.06, and best deficit -9.
So what's going on? What happened, Al-Anud?
There is respiratory acidosis with increase with oxygen requirement and bradycardia.
So
maybe have to, could be RDS or pneumothorax.
I agree with you. Pneumothorax. This is a sudden changes, right? So so that's a sudden changes. He was okay, stable, and suddenly dropped. So that would be a okay. How do I refuse this call? Whatever. Can you still hear me?
Yes.
Right. And so that's a pneumothorax. What would be the next bedside test you do? Bedside test.
I would like to auscultate and seeing to listen where is the decrease of air entry, then needle.
Right. And I would do a transillumination test, transillumination, like Abdullah said. And what's the gas is showing you? You said respiratory acidosis, and what would be the ultimate treatment is insert chest to drain initially for this tension pneumothorax, which is needle insertion to relieve the pressure, and eventually you need the chest tube. I agree with you. Okay, slide Tali Salah. دكتور عبد الله يتيمي تفضل. اوكي تفضل دكتور عبد الله. دكتورة منال، دكتور عبد الله، اي واحد تفضلوا. This is a slide trying to test you if you appreciate the genetic tree, the family tree. Okay.
This is the family tree of family with inherited disorders and mutation in gene located on chromosome 7. Further,
so what is the mode of inheritance?
This is autosomal recessive inheritance.
Why would you say so? I agree with you. This is autosomal recessive, yes.
Because both the parents are carrier.
Exactly. And what is the chance of affected child?
It is 25%.
Excellent. What is the chance of a normal child?
25%.
What is the chance of having carrier childs?
50%.
Excellent. 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 Okay. And okay, that's about it. I think that's the drive home message from this slide. They might ask you, give me a example for autosomal recessive. So have something in mind, okay? Slide التالي صلاح. What about this one? دكتورة منال, دكتور العنود, أسرار, محمد, عبد الله.
autosomal dominant.
لا, this is mitochondrial disorder. Mitochondrial.
Okay, who said mitochondrial?
منال, أنا.
Dr. Manal, explain to me, at your colleagues, why it's mitochondrial.
Because this
Actually,
is...
hold on a second, Manal. You spoke a lot. Thank you for your effort. Nada, you're raising your hand. Go ahead, Nada. Thanks, Manal, for your effort. You're doing really well. Fantastic. I'm proud of you. Nada. Are you going to speak up, Nada, or no? If no, then Manal, take it. Oh, Nada says I don't have mic. Go for it, Manal.
Okay, this is mitochondrial.
Why is mitochondrial?
Because always my mother is spread the disease while the
exactly.
Yeah.
I'm
While
really
the
proud
boy-
of you. You see, the mom, when is affected, it's passing to the
whole kids, يعني
all kids. When the dad is affected, is not passing it down. So this is a mitochondrial inheritance. Mitochondrial inheritance is the mom issue, right? Excellent. Good for you. Slide تالي صلاح. Okay. So I think this is for you. Autosomal dominant, it doesn't skip generation. Autosomal recessive, skip generation. X-linked is usually the mom moving it to the kids, and the dad doesn't because it comes from the mom. The same thing for X-linked. The mitochondria is the mom's always passing to the kids as well. Next slide, Salah. Slide التالي Salah. Okay, that's the same thing. It's basically nothing different about mitochondrial disease. The slide tally. Okay, so this is a karyotype. I mean, I'm giving you the answer because I'm putting the circle. Can anybody take it?
This is trisomy 21, Down syndrome.
21. So basically, the take-home message from this slide, you need to be familiar looking at karyotyping, okay? Look at the chromosome 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 18, 19, 20, 21, and 22. 22 chromosome autosomal, right? And you have the X and Y, right? And or the X and X. Slide تالي صلاح. Okay, what is this one? Can somebody, mom brought you to the clinic, this report, and say, doctor, they gave me this from Riyadh. I don't know. They did not explain to me. They did not do counseling. And she asked me for counseling. What is that? Okay, Asrar, Asala, one of you guys.
Yes, doctor. I see this is a karyotype sheet with result written as a 47XX plus 21, which goes with Down syndrome.
Right. So there is 47XX and there is 46XX. So what is that?
Extra chromosome.
Right. So the problem is where? What is that called? Sarah, talk to me, Sarah.
Yes, doctor.
Yes, go for it.
Since there is a different type of cells like 47XX and 46XX, it goes like with the mosaicism or mosaic pattern.
Mosaic trisomy 21. This is mosaic Down syndrome. Okay, you got to be careful. Excellent. Good for you. If they gave you only 46XX and with extra copy in the 21 chromosome alone, this is trisomy 21. If they gave you another slash, that means they analyze other cell and there is a 46XX. They analyze 6 cells that has this 46XX, and they analyze 15 cells that has 46XX plus extra copy in the 21. So that's a mosaic, mosaic Down syndrome. Next, Salah, slide tally. Okay. Nada, go for it. Asala, Lanud, Asrar, Muhammad, Abdullah.
Okay, doctor, I will read it. This is an ataxic 3-year-old girl seen in pediatric neurology clinic. The blood film is normal, MRI generalized brain atrophy, normal amino acid, alpha fetoprotein normal, lactate normal, CSF lactate 1.2, the very long chain fatty acid normal, neuroconductive and EMG normal. The urinary VMA is high. So most likely it's going with neuroblastoma, maybe.
What do you think?
I'm not sure, صراحة.
So you have a MRI. MRI is generalized brain atrophy. So generalized brain atrophy. And you have amino acid and organic acid is normal, so that's against homocystinuria. You have alpha fetoprotein that is within normal limit. Although I would have told you usually later in life they will have high alpha fetoprotein. The CSF lactate, plasma lactate is normal. VELCAD is normal, which is against the Zellwegers and whatnot. And nerve conductions and normal. And you have high VMA, right? And the child is ataxic. So this is a scenario for what? So this is Ataxia-telangiectasia. This is Ataxia-telangiectasia, and they will have risk of neuroendocrine tumors, so they will have a VMA. This is a trick question. This is not a neuroblastoma. Neuroblastoma, they will have normal brain. This is a generalized brain atrophy. So this is 3 years. So this is Ataxia-telangiectasia, right? So the other physical finding they ask you, say telangiectasia in the ear, in the face, and the eyes. What do you look in the eyes? You look for nystagmus. How would you test them? You do immunoglobulins. You look for the hyper IgM, like high IgM. And you do a DNA breakage studies, and you do abdominal ultrasound for a hepatoblastoma. The slide tally, Salah. سلايد تالي تمام انت نقلت اصلا okay, so this is this is X-linked AGAM. Okay, so you have 2-year-old ulcerated skin lesions, no lymph nodes noted, and has a frequent otitis media. He's failing to thrive, blood culture Pseudomonas, and you look at his immunoglobulins, all are low. This is AGAM. Okay. Slide tally, Salah. Okay, any taker for this? A child can build Tower of 8. This is what he can copy. What is his age?
4 years.
4 years.
Why it's 4 years? Why it's 4 years? And Gina, why is it 3 years?
Yes, doctor, he is able to draw a square, cross, and circle by 3 years, across 3 to 4, and the square by 4 years.
Right. So I agree with you. That's kind of more sitting, although the right answer in the textbook here, it says 3 years, but I agree with you. Square is 4 years. So I would say 3 to 4 years. Okay. Okay. Slide Tali Salah. Skip slide Tali Salah. We said we don't do cath. Slide Tali. Okay, any taker for this question? You have 1-year-old boy with a failure to thrive. His birth was 4 and has been breastfed for 6 months. At the age of 1 year of his age, 1 year of age, his weight is 8 kilo. White blood cell normal and hemoglobin is normal, platelets okay-ish. Blood film has hypochromia, anisocytosis, and acanthocytosis. Acanthocytosis. X-ray of the wrist shows evidence of ricket. Serum cholesterol is low, and stool shows fat globules. Manal, what do you think?
I think this cystic fibrosis case.
Right. So let's cystic fibrosis. Okay. I did not give you the history he had. He's 1 year. At least admitted to hospital for repeated chest infection. So I did not give you that. I gave you only failure to thrive.
Right, yes.
So what's the issue? Failure to thrive. He's not absorbing fat. He's having fat globules. And he has rickets, which is basically fat-soluble vitamins not getting absorbed like vitamin D.
Yep.
And the buzzword, the blood film has acanthocytosis. This is the word acanthocytosis is something. So this is a scenario of Abetalipoproteinemia. Abetalipoproteinemia. They present with the fat malabsorption, and it's you diagnose them with you do a lipid. The next step would be a lipid profile. It's a genetic. It's a autosomal recessive disorder resulting from the lack of synthesis of apoprotein B, which is essential for the formation of the LDL and the very low density lipoprotein and the chylomicron. That's why you have the cholesterol level is very low, less than 1.3, and triglycerides very low. And they have diarrhea, fat malabsorption, bleeding due to vitamin K malabsorption as well. And the buzzword is acanthocytosis, basically spiky red cell. Spiky red cell, acanthosis. Acanthocytosis is always present from birth, but is not pathognomonic for it, okay? So that's what it is. You support them with protein, you support them with ADEC and basically frequent follow-up. What are they are risk of? They are risk of ataxia and retinitis pigmentosa. Ataxia and retinitis pigmentosa, right? They usually, ataxia and retinitis pigmentosa, they appear at the end of the first decade after 10 years, and they're usually progressive. They have a profound neurological features issues, like basically to vitamin E deficiency, right? And they usually die from a cardiac arrhythmia. You treat them with vitamin E to prevent the development or progression of eye and nervous system. And you also support them with vitamin K and A and D and low-fat diet. is also recommended, and you give them MCT oil. Okay, next. Okay, anyone? صلاح can you صلاح ممكن تجي الغرفة الله يرضى عليك. Anyone take this question? Come on, guys. I'm already 50 slides and I have 92 slides. So.
Okay, I can read it.
Okay.
This is a 7-year-old child present with status epilepticus. The seizure terminate with emergency department. These are the investigations result. Of note in the past is a history of pica. Hemoglobin is low. Total white blood cells is normal. Platelet normal. Calcium maybe a little bit high or normal. Glucose normal. Sodium low. Potassium normal. CSF no organism. Or I think RBCs will white blood cells there is high white blood cells. It should be 0, I think. Protein is normal, maybe.
Right. I mean, if you correct the white blood cell to the RBC, I think that
would be normal,
because that's a traumatic step, right?
Yes.
The amino acid is positive, the protein is positive in the urine. So basically, he is dumping. Basically, he's having a proximal nephropathy, like a Fanconi-like picture. That's why he's dumping the protein. And so there's something happening that's connect status epilepticus, connect pica, connect low sodium, and connect Fanconi-like proximal nephropathy. What would that be? Dina, what did you say? You got it right, Dina. Speak up.
Could be lead poisoning.
Lead poisoning.
Yeah.
Lead. So it's not lead poisoning.
Yeah.
Lead someone. It's lead poisoning.
Yes.
Because I hear a lot of my Saudi colleagues say lead poisoning. It's lead poisoning. Okay, so it's lead poisoning. The next step would be so this is a lead encephalopathy scenario. Okay, so the test they wanna appreciate when you have a child with pica and anemia. So you have pica, anemia, status epilepticus, and I have a protein in the urine. This is a lead nephropathy, lead encephalopathy picture. You want to do serum blood level. You want to do long bone and abdominal X-ray looking for the lead deposit. Okay. So, slide التالي صلاح. Okay. Dina. تفضل Dina.
Okay, 6-month-old infant is referred with failure to thrive. He has been constipated since birth. His milk intake is 120 ml every 2 hours. He walks during the night crying, but he will go back to sleep after feed of 120 ml of milk. Sodium is 131. الهيموجلوبين 12 البوتاسيوم 2.7 كلورايد 8.5 البلاتلت 190 الكرياتينين 45 البروتين 30 اليورين في الصوديوم 10 والبوتاسيوم 60 البي اتش 7.50 والبايكاب 30.
So what's going on? Can you analyze it for me?
This patient could be in constipation since birth, could be Hirschsprung disease.
So, okay, so that's Hirschsprung would explain your, guys, you're things I cannot see because I'm looking at the screen and speaking from the from the phone. So if you have any thoughts, just feel free to speak up. So Hershapran can explain. Sheikha, you want to talk to me, Sheikha? No?
هلا دكتور.
هلا تفضل.
This is 6 months old, hyponatremic, hypokalemic, metabolic alkalosis. So most
Right.
likely goes with pyloric stenosis.
Okay, so this is
Hyponatremic, hypochloremic, metabolic alkalosis.
hyponatremic.
Hypokalemic, hypochloremic.
Let's see, hyponatremic, hypochloremic, hypokalemic, hyponatremic, so it has to be hypernatremic, hyperkalemic, hypochloremic, metabolic alkalosis. So that this scenario does not fit. Okay. So the only thing can explain low sodium and low potassium and low chloride in a setting of a kid is waking up during the nights and probably want to ask for milk and a drink that much and go to sleep. That's a scenario of a not cow's milk or protein allergy. That could be a DI scenario, whether it's a nephrogenic DI or central DI, or could be psychogenic polydipsia, right? So especially when you have a lot of dumping of potassium in the urine. Slide tally. Okay. You have 10-year-old brought to the emergency department by her mother. She developed worsening swelling around her face and eyes, around the eyes and the ankle during the afternoon. Her father died suddenly from upper respiratory tract obstructions of uncertain etiology 10 years ago. You look at her urine, normal, no protein. Her hemoglobin, her CBC seems to be okay. Her electrolyte seems to be okay. Her liver enzymes, billet, okay. Protein is okay. IgE is high, C3, C4 normal. What is that? Anyone? Quick. No. So that is with the setting of family history of sudden death. I mean, you could argue this is anaphylaxis, but what they're getting at, especially with the giving you C3, C4, that's angioedema. I agree with you, Asrar. This is familiar hereditary angioedema, and you would test it with what's the investigation of test? Investigation of choice. Well, somebody says C4, Al-Anud said C1. I agree with you, Al-Anud. This is C1 esterase inhibitor deficiency assay, and you refer them to allergy immunology for further workup, probably for hydrocortisone, for any histamine, and further follow-up, because there are risk certain tests. So probably danazol is the treatment of choice. The reason for that is usually because it raises the C1 esterase inhibitor level, and to prevent the attack. The contraceptive preparation may help in girls, especially in the post-pubertal period. So the problem is in the there is a C1 esterase inhibitor deficiency. That's the problem. That's why danazol is gonna raise those. Okay, slide tali Salah. Okay, so you have a child that is presenting to you with, she's 2 months, presenting with a lot of lethargy, irritability, and he's been refreshed normally. He received a mix of fruit juices on the day of the admission. So that's kind of classical scenario. 2 months fed juices, fruit juices, whatever. I mean, it's too early to feed him, but mom fed him. When she went staying with the friend, they gave him this. He started vomiting, and he became acidotic. He was sick, and the lactate is high. It's basically shock, like kind of picture. And he started dumping glucose, amino acid, proteinuria, and used. Oh, by the way, you did the test. Excellent. Asrar, talk to me.
Yes, doctor. I think this patient, as he's having hypoglycemia after he drank juice, it's most likely positive fructose intolerance.
Right. So this is a primary unborn error of metabolism. It's called the fructose intolerance. It could be fructose intolerance, and it could be either a fructose 1,6 diphosphatase deficiency or a fructose 1-phosphate aldolase deficiency. This child needs a GI consult and metabolic consult, and she eventually would need a liver biopsy. Right. Next is slide تالي صلاح.
دكتور نوقف هنا أو ناخذ سلايد؟ إنه باقي 4 دقائق على الساعة 10 بالضبط.
والله بكيفكم.
على راحتك دكتور.
على راحتكم انتم، يعني نوقف. انا باقي لي انا وصلت 53 هسه. باقي لي صلاح اذا تمشينا بالسلايدات، بس خلينا نشوف الانترستنج سلايد. بس مشينا بس لحظه. لا مو هيك، لا على كيفك شوي، سريع انت كلش. صلاح ارجع للسلايد الاول اللي احنا كنا واقفين يمه، ومشيني واحد واحد. يعني انت بعيد يمي. ورا لحظه. Okay, this is a scenario of galactosemia. Okay, ورا واحد شوي. This is obstructive. Okay, let's take that. Anyone? راح نمشي selective، نمشي ونشوز، نختار بس الدسمات يعني. Anyone? Okay, Manal, talk to me.
11-year-old girl seen in the chest clinic with a history of chronic cough and poor growth development. Lung function tests are performed. FVC, there is pre and post bronchodilator. So post is high. FEV, pre and post is high, more increase, I mean. So ratio is pre 87 and post 95. It's going with obstructive lung disease. I think most likely cystic fibrosis due to poor growth development and chronic cough.
I agree with you. This is a obstructive lung disease due to cystic fibrosis. The test you need to do a sweat chloride, blah 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 blah. And could be PCD as well, primary ciliary dyskinesia. So you need to do some sort of bronchoscopy and biliary, yeah. Slide تالي صلاح. سلايد تالي. هذا fasting lipid profile familial hypercholesteremia. سلايد تالي. Okay, I think that's interesting. Manal.
This 4-year-old boy is referred. He can walk but no run. He often trip over. He can copy a circle, cross and square. He knows 6 colors and occasionally speaks 3-word sentences. He can understand game rules and share them with others. What is the differential diagnosis?
Okay.
He 4-year-old. I think he
trip over, he falls.
This is gross motor delay, maybe the chain.
Yeah, that could be myopathy, could be cerebral palsy. What is his gross motor developmental age?
Delay. Gross, I think 12 months maybe, or 18
Excellent, I
months.
agree with you. He's 12 to 15 months. What would be the list of 3 investigation you would do? If you would think this could be Duchenne, he's a boy.
Okay.
So you would do a CK, you do EMG, you do brain and muscle MRI, and basically, okay. Next.
What? Okay, go.
Yeah. صلاح السلايد التالي. بس لحظة خلي أشوف. Okay, so that's hemophilia A and B. Okay, slide تالي. احنا تكلمنا على bleeding tendency. Slide تالي. Okay. This is okay. I think that's whoever who wants to take this one. I think that's another domain. I think you might get tested on it. So 5-year-old admitted with the history of drowsiness and unsteady gait, suffered from generalized tonic-clonic seizures at home. She has a similar episode at the age of 8 months and 16 months. Her siblings died at the age of 6 months with the progressive seizure disorder and failure to thrive. Progressive. Investigation, sodium is okay, potassium is okay, BO and creatinine and glucose okay, lactate is okay-ish. LFT is normal. Ammonia is quite high. Ketone is low. CSF okay-ish. And you've done EEG. There is a spike and slow waves. So that what's going on? I have ammonia, and oh, by the way, I told you there is no acidosis. By the way, there is a alkalosis. Just to make it easy for you, what is that? What is that? So that's a urea cycle defect, okay? So you need to, when you have a ammonia, you have a progressive neuropathy, you have seizures, and you have a family history of similar, and you have a high ammonia, and you have a alkalosis. Think of urea cycle defect, okay. Slide تالي صلاح. So basically, when you have high ammonia, think about it. Do I have ketone? No, I don't have ketone. If I don't have ketone, think about the urea cycle defect, which is a primary hyperammonemia, whether it's ornithine, whether it's the CPS or the arginase or the ASL or the SS, and that's the test. If you have positive ketoacidosis, think about the organic aciduria. So that's basically the summary for hyperammonemia. Slide تالي صلاح. Slide تالي. So that's not important. Slide تالي. Slide تالي. Okay, so we talked about the dumbbell. What of the dumbbell that could be the reason for this girl? And what's the gas is showing? Just go for the what is it? Anyone? Okay, so that's a scenario. 11-year-old found to be comatose, sweating profusely. Her mother suffered from heart attack 1 year ago. Her blood gas is, you look at the urine, okay. Sodium is low, potassium is low, and the albumin is low, urine reducing substance. So what could be? What's going on here? Anyone? The pH is low with normal PO2 and a slightly low PCO2. What does that mean? So you have a metabolic acidosis with mild respiratory alkalosis, right? So not sure. Yes, that's exactly it. Whoever said Asala, talk to me.
Yes, hi, doctor.
Right.
So most likely with this age and the mother was taking medication for this heart attack and metabolic acidosis with respiratory alkalosis, going with aspirin.
Excellent. This is a salicylate poisoning, especially when you have low pH and you have normal PO2 and a slightly low PCO2 because it's hyperventilating. At the same time, you have metabolic acidosis and mild respiratory alkalosis. This is a aspirin ingestions. Okay. Slide التالي صلاح. Okay. Slide tally. Slide tally. Okay, so 2.5-year-old has a normal motor developmental skill. He seems to be very shy. He plays alone, has no eye contact with the others in the room. He has minimum understanding of verbal words. He can say more than 10 single words. Okay, so that's autism. What is the age of his language development? Manal, what's the age of his...
Doctor, 1 year.
Excellent. 15 to 18 months, kind of, because he's saying more than 10 single words, no sentence, probably more than 1 year, 15 months, probably. Excellent. Excellent. Okay. Slide Tali Salah. So what's the difference? What is this type of milk? I think that's hard. The mother is feeding this milk, and they ask you, what's the type of this milk? This is likely cow's milk. What's the difference between cow's milk, this milk, and the breast milk? This milk has high protein, high calcium, and high phosphate compared to the mom milk. If they ask you that, I really doubt it. Okay, next. Salah, slide ثاني. تالي. تالي. اللي ورا. اللي ورا يا صلاح. تالي. التالي. Okay, 9-year-old present with the history of progressive loss of vision, painful eye, and she has an area of numbness on her face. Endoscopy, fundoscopy revealed bilateral papilledema. She becomes ataxic, and her MRI shows area of demyelination in both cerebral hemisphere. What's her diagnosis? Right. I mean, ADEM, and also especially with the area of demyelination and become ataxic and bilateral papilledema and numbness in the face and a progressive loss of vision and painful eye, I would go with the multiple sclerosis more than ADEM. And I would send the CSF for oligoclonal bands, and I will do MRI spine. I will do visual evoked potential, and as well as probably consult my neurology to start a steroid. Slide Tali Salah. Okay, I have this 7-month-old presenting with the continuous seizure and required ventilation. He looks dysmorphic. He has a sparse, kinky hair, and he has low set ear, and he has VUR on the mega scan, MCG scan, which is VCUG scan. Just no reading, no further. And MRI, yeah, so Menkes syndrome. This is Menkes syndrome. You need to do molecular genetic study, and you do a hair for microscopic study. What is Menkes? Menkes is X-linked recessive. It's opposite to the Wilson. It's basically the problem in the copper deficiency, right? Okay, so it's Menkes syndrome. Okay, slide tally. Again, this is a scenario of another mitochondrial disorder because you have myoclonic jerk controlled by clozapam. You have global developmental delay. Parents are consanguineous. You look at the ammonia seems to be normal. The lactate seems to be slightly high. The rest of the workup, the brain MRI, yes, that's MELAS. Manal, tell us what's MELAS. And you have brain atrophy. Okay, MELAS. What's MELAS?
MELAS is mitochondrial encephalopathy, lactic acidosis, stroke-like events.
Excellent. You have the lactate slightly high as well. I agree with you. Proud of you. Very good. Mashallah alayk. Mitochondrial disorder, you need to send white cell enzymes, and you need to do skin biopsy for tissue fibroblast. This is MELAS, okay? And especially the lactate and pyruvate from the blood is very high, and you do the lactate pyruvate ratio is usually more than 50:1, suggests the metabolic block in the respiratory chain. Okay, so slide tally, Salah. A 10-year-old present with vomiting, lethargy, and they are a brain, no abnormalities, and the bell count is normal, amino acid normal, ammonia is quite high, okay, so pH, there is acidosis. Okay, so that's organic acidemia. I agree with you. Okay, good. Because there's acidosis and ammonia, so this is organic acidemia as we agreed earlier, right? And I would like to see if there's any ketone or not, but that's fine. Okay, next. Slide tally, Salah. Similar or metabolic, this is a 6-year-old seizures, happened twice in the morning, lasted for 2 minutes. You look at his lactate, okay, glucose is low, carnitine is high, and what is this? Yes, fatty oxidation defect, and you send off for with the very long chain of fatty acid profile, and you do for acylcarnitine as well. Slide tally, Salah. Three-month-old history presenting with, this is all metabolic. We're trying to beat up metabolic. So you look at this lethargy, jitterness, not feeling well. He has the only abnormal, you look abnormal high alanine, low phenylalanine, and taurine. So that's phenylketonuria. Okay, so that's the scenario of phenylketonuria, and you have the rest of the workup. Slide, Thani Salah. Okay, Ilwara. Anyone can take this one. This one is interesting. خلصنا وصلنا تقريبا 78 على وشك الانتهاء. Anyone?
I will read it, Doctor.
Okay.
This is 5-week-old
I will
boy
read it. Give me your impression, okay? Okay. 5-year-old boy present with history of vomiting with his mother says he can reach to the other of, okay. What is weak? Manar, what is weak?
5 week and good 5 year.
Oh, 5 weeks, sorry. I thought that's a diagnosis. Okay. So the pH is alkalotic, right? And the rest of the workup seems to be okay. Oh, and I told you he has hypochloremic metabolic alkalosis. And he has a
So
project.
this is
That's a
pyloric stenosis.
I agree with you, Manal. Thank you. Nada, I agree with you. So that's a pyloric stenosis, need pyloromyotomy. Okay, slide tali, Salah. Okay, so that's a 25 years old present with jaundice, non-consanguineous. You look at the jaundice, the IPTT is prolonged, INR prolonged, so that's a biliary atresia. Excellent, thanks, Asrar. You need to do a Kasai procedure. Next, slide stand, Salah. Wara. 13-year-old present with joint pain, swelling, mild fever up to 38. He has anemia. He has a ANA positive, double-stranded negative, and he has joint pain. So that's a juvenile arthritis. Okay, consult rheumatology. Yeah, JIA or juvenile rheumatoid or juvenile idiopathic, whatever you want to call it. Slide tally, Salah. This is a scenario of anemia of prematurity. You need to be comfortable with it. Slide tally. Okay, so that's a 10-year-old present with lethargy, no feeding. So basically have high 17 OH. So that's, yeah, CAH. So perfect. Congenital adrenal hyperplasia. Slide tally. That's interesting. Whoever want to take that, that's a nice one. Okay, what is that? A 15-year-old presented with the sparse pubic hair. What is the clinical problem? So she had a precocious puberty, secondary to CAH. Okay, good. What do you need to do? You need to do a pelvic ultrasound. Slide tally. الورا. That's a growth hormone deficiency. You need to do a stimulation test. الورا. That's congenital. That's a hypothyroidism. Okay, الورا. So they come in clusters. So we gone over all the rest. We gone over the cardiac, hematology, now metabolic, now genetic. Now we're done the endocrine, right? Okay, so what is this? Floppy baby, 3 months, reflux is absent, upper or lower limb, and you do head and brain MRI and increase the spinal and the lumbar region. So that's a transverse encephalomyelitis, right? Or maybe it could be botulism, but botulism doesn't give you the increased signal in the lumbar region. So that's a transverse encephalomyelitis, whatever the reason is. You need to consult your neurology. Okay, slide, Tani. Okay, so you have, this is a proximal weakness. You have CK, so this is myopathy again. Slide tally. Liwara. So that's the scenario of aseptic meningitis. Because he has focal seizures, he started being unwell, lethargic, having focal seizures, and you do a CSF, you see RBC there, and you see the gram stay negative, and you see EEG showing wave activities, and no show wave activity, but no vocal discharge. This is a septic meningitis. You need to rule out HSV, so sent for CSF PCR, right? Slide tally. Yeah, so that's interesting one, just before the end. 7-year-old present with the history of ataxia, dysarthria. She's ataxic, she dysarthric, she is dysphonia, she cannot talk normally. When you talk to her, she's like she has hot potato in her mouth, like it's like a nasal speech, right? She cannot swallow. If she swallows, the food comes from her nose, right? She has poor tone and poor reflexes and upper limb, power and tone and reflex in her upper and lower limbs entire normal. CSF shows no abnormality. PCR for HSV is negative. What is it? What is this? What is it? Come on. ADEM, myasthenia. Okay. Botulism. I'm asking you the problem, the description of the problem, not the diagnosis. So this is bulbar palsy. Bulbar palsy, the only thing you can differentiate between bulbar palsy and pseudobulbar. Bulbar is a lower motor neuron lesion. Pseudobulbar is upper motor neuron lesion. They present exactly the same. The only difference that the pseudobulbar usually has a exaggerated reflexes, where the bulbar is depressed reflexes. And basically also the pseudobulbar usually present with weird emotional out controls called uncontrolled laughing, and they start laughing with no reason uncontrollably, and they start crying without reason uncontrollably, and they're usually stiff and spastic, where the pseudobulbar, the bulbar is more in the lower limb. It's basically like a brain stem stroke or botulism or motor neural lesions like ALS or infection, where the pseudobulbar like stroke, multiple sclerosis, or higher brain injuries. So that's, you need to appreciate the difference between bulbar and pseudobulbar. Okay, final slide, slide al-akhir. And so that's the ADEM you've been waiting for. A lot of you guys been saying a lot of ADEM. So 10-year-old present with abnormal movement in her arms, legs, which looks like spasm occurring every 10 to 20 minutes. You look at her CSF. Basically, it's everything is normal. The CRP seems to be slightly elevated. You do serum amino acid, urine organic acid seems to be MRI of the brain shows white matter changes. So that's what the ADEM. Okay, excellent. Any question? So basically, this is ADEM. The ADEM usually follow a viral illness or measles immunization. Sometimes, in some cases, has no. You cannot find a cause, right? And it's usually abrupt onset, may consist of loss of consciousness, of seizures, and you do the CSF. The CSF shows a lot of cell pleocytosis and mild increase in the protein. Immunoglobulin oligobanding test should be done to differentiate ADEM from the other demyelinating disease, such as multiple sclerosis. MRI shows increased signal on the T2 weighted images, usually involving the white matter. So that's the trick, is white matter. When you hear the white matter, diffuse involvement, so that's kind of ADEM, okay? Spinal cord lesions are clearly seen and may enhance gadolinium, okay? Treatment usually supportive if the diaphragm is involved and bulbar nerves are involved. Corticosteroid can be given treatment for this condition. Usually with the treatment, more than 70% will recover. I wish you guys all the best. You've been great.
مشكور دكتور محمد، جهد كبير تشكر عليه. يعطيك العافية.
الله يعافيك.
الله يعافيك ونفع الله بالتوبة عندك يا دكتور، يعطيك العافية. أي سؤال للدكتور على السريع؟
شباب بنات أي سؤال؟ I take it there is no questions. Okay. You guys have a good night.
Yeah, good night. يعطيكم العافية. شكرا جزيلا.
السلام عليكم.